A big point that I think has come, that I think we are promoting in the urology world especially, is the concept of, as Chuck, you alluded to earlier, treating early. Identify these patients earlier, because we now have all these great therapies, albeit in monotherapy trials. We all have these great therapies that have a survival benefit. And so, you know, one of the early articles that came out, and actually, Mike, this is from your senior partner, Pal Shellhammer, is really looking at the IMPACT trial, which was the registry trial for Sipuleucel-T, in terms of looking at the PSA quartile data. So, Judd, can you walk us through and the importance of this paper?
So I think we're all familiar with Provenge, or Sip-T, FDA approved in 2010, and if we think back, gosh, it's been 5 years ago, that was the first agent that started the train of the 5 or 6 new agents in prostate cancer. And it was controversial right from the start. It's an immunotherapy, it's custom made for that individual patient. For those who may not be familiar, patients come in for a plasmapheresis. The product is then sent to currently Atlanta. It's an activated immunotherapy that comes back and is infused in the patient. Patient receives 3 infusions over approximately 4 to 5 weeks. Duke, at our institution, we've been proponents of this product from the start. I think at one point we might have been the highest infusion center in the country. I know it has, it rotates potentially between Duke and UCLA and UCSF, but so we've been proponents of it. But it was always controversial. There was a 4.1 month median overall survival comparing patients who received Provenge versus patients who received a frozen, some people call it Provenge, but it was a group of patients who received could receive an infusion. It was placebo controlled, but then they could receive this other infusion. But the key teaching point, this overall 4.1 survival benefit, the product was costly. It was fairly complex it wasn't that complex to administer, but it seemed complex. So it really never caught on at a lot of institutions. However, just to follow up on what you mentioned with Paul Shellhammer, the secondary analysis of the IMPACT trial looked at response and survival based on the starting PSA before patients received the product. And that's called the quartile data, breaking it down in quartiles of PSA. And the most impressive finding to me was that in those gentlemen who had a PSA less than about 22, from a practical standpoint, a guy in your practice who has metastatic castrate-resistant prostate cancer with a lower PSA below about, say, 25, the response to Provenge versus the placebo arm was striking, over a year survival benefit. And I believe that data. It makes sense from an immunotherapy standpoint, but from an academic standpoint, the challenge of the quartile data it was a secondary analysis. It was never a pre-specified analysis with the FDA. So you basically have believers who think that that product makes sense and should be sequenced early, and then you have non-believers who just don't believe that this immunotherapy should be used.
I think one of the other questions is, does immunotherapy help all patients a little bit, or a minority of patients a lot, and a majority of patients none, not at all? And I think that's what that quartile data brings to my mind as I look at it. I use it exactly in that setting, which is I look at the patient, I try to prognosticate, is this a person who's going to live 3 years? And if so, Sipuleucel may be a viable treatment for them. And of course, it's really important to keep in mind that in the IMPACT study, there was very little to no penetration of enzalutamide or abiraterone and other things. So there's a lot we just don't know about the current era in using this agent.
But if you think about immunotherapy, it should attenuate the disease, right? That's how it's working in other cancers. I mean, personally, if I could give Provenge at the time of diagnosis, at the time of their biopsy, that's probably the most useful. Unfortunately, it wasn't studied like that or approved. But if you think about it, it's attenuating the disease.
Maybe.
It doesn't have PSA, maybe.
Yeah, I mean, the argument against that is that maybe those early patients don't have enough antigen out there to benefit
Correct.
from it. So maybe the PSA below 22 or whatever it was in the lowest quartile are those who are in that sweet spot of having enough antigen and enough disease for the immune system to be harbored, for it to be accentuated, but we just don't know.
I mean, I think the key point for urologists who are listening in on this program, watching this program, is most of those patients are in urology practices. Those early castrate-resistant disease patients, if it's going to be beneficial, we need for the urologist to identify those patients, be aware of it, and either do it themselves or refer those patients to a center of excellence where it can be administered.
Right, I think it is incumbent on the urology world for just what you said. I mean, it's made it into the guidelines now. So when you look at the AUA guidelines where they've tried to go through and find really good level 1 evidence, and they've tried to take into account performance status, that clearly the most beneficial patient is going to be that index patient 2 that's completely asymptomatic, has a significant survival to their overall health, and really would hopefully see a benefit from immune therapy. And then when the most recent NCCN guidelines that came out in 2015 basically says the same thing. If you've got a ECOG 0 patient who's going to live at least 12 months, who's completely asymptomatic, you should be, again, considering Sipuleucel-T. So again, but then you run into the whole controversy of, again, the layering and the sequencing, and again, like the discussion with radium, there's no PSA effect, so we have to kind of bring people off the ledge that their PSAs may go up.
And you hear that argument less now about the PSA
Right.
effects, but I would say it's a fairly innocuous drug, if I can use that word.
Yes.
I mean, you get a little low-grade fever at most with the infusions. We rarely see. So this is something that you have strong evidence. You can debate the studies, but it's there, and there's 2 of them, and you can give this drug with relative ease very early in that arm, in that metastatic castrate-resistant arm.
And I think, like Chuck was saying, one of the things that's so important to these patients, because many of them are asymptomatic, is this concept of preservation of quality of life. They can get this therapy, and Judd, like you said, it's 3 infusions within 4 to 5 weeks. It doesn't slow them down. They continue to play golf. They continue to take their grandchildren places, mow the lawn, or whatever.
A couple other practical points. We get fewer, as a urologist, I kind of get fewer callbacks from this than I do with BCG. So
Yes.
it is well tolerated. Just to follow up on Mike's approach with radium-223, at Duke we have a central coordinator, we have a physician's assistant, and this is her project. And so whether it's a urologist or a medical oncologist, we can work with our PA, our Provenge PA we call her, and get it done. And those patients the drug can be written by either urology or medical oncology. So that gels the team too, because we're working with the same coordinator.
There is one thing I think we should